The next talk will be by Michael David, and it's entitled Developing an Agent-Based Model of MRSA in the Community, Establishing Agent-Level Parameters for Risk of Transmission and Infection. Michael? Okay. Oh, great. Excellent. Thank you. Alyssa's on top of everything here.
Great. Thank you. Good morning. So this is an outline of my talk for today. First of all, I'm going to say a few words about the agent-based model that we're developing for community-associated MRSA in the city of Chicago. Then I'm going to say a few words about community-associated MRSA epidemiology in the United States. And then I'm going to describe some challenges that we've encountered to deriving model parameters for our agent-based model. And then I'm going to share some new data from a national survey that we very recently completed to realistically vary behavioral determinants of risk for a longer infective period in agents in our model, risk of infectivity, and risk of recurrent infection. So first of all, we have an NIH grant through the MIDAS program to develop an agent-based model of community-associated MRSA. And we have an interdisciplinary team at the University of Chicago and at Argonne National Lab to build this model. The goals of the model are to develop a novel agent-based model in one city for community-associated MRSA, which hasn't been done before, to represent transmission dynamics in this synthetic population, represent places with associated transmission risk and geocoding, to model future scenarios in the epidemiology of this pathogen, and to test preventative interventions. This is a screenshot of the output from the preliminary version of our agent-based model. It represents one zip code in the city of Chicago. It's actually the zip code where I live, 60615. And as I mentioned at the last MIDAS meeting, this is also the zip code where President Obama has his house a couple blocks away from me. There is MRSA there, I can assure you, because I work a few blocks away at a hospital. And in our model, we seeded this population with a few people who had community-associated MRSA and let it run for a month. The platform for our model is called Repast Symphony, which is an agent-based modeling program that was developed at Argonne National Lab by two of our co-investigators there, Chick Makel and Michael North. So I'm a doctor and I'm also a historian, and so I can't resist telling you something about history and how history may be repeating itself. So this is a diagram. You've heard a lot about MRSA and Staph aureus beta-lactam resistance from previous speakers. But this is a diagram, a timeline of 110 years, showing the major introductions of beta-lactam resistance in Staph aureus. And these data are cartoon and put together a lot of data that others have collected. So penicillin was introduced in the early 1940s, as you all know, and was a wonder drug. Prior to that, mortality rates from Staph aureus bacteremia were 80%. Now they're approximately 20%. So within a year of the introduction of penicillin, penicillin-resistant Staphylococcus aureus, or PRSA, was recognized. Gradually, over the next 40 to 50 years, it became almost universal in Staph aureus isolates from infections in the United States. Now approximately 90% of isolates from infections are resistant to penicillin. Then, after the introduction of the beta-lactamase-resistant penicillin methicillin in the early 1960s, MRSA was described in the UK, and then the first outbreak of MRSA in the United States was in 1968 here in Boston. Subsequently, MRSA became more prevalent in U.S. hospitals, first large academic medical centers, and then general community hospitals as well, to the point where in approximately 2003, about half of all Staph aureus infections in hospitals were caused by MRSA strains. Then the third event was in the late 1980s, when MRSA strains appeared in healthy people in the United States for the first time. After a slow start, they started to spread much more rapidly, to the point where now, in a number of American cities, about 50% of Staph aureus infections in the community are caused by MRSA strains. And these strains are not escaped strains from healthcare facilities, they're novel strains that newly emerged. And the one predominant strain that you've already heard mentioned is USA 300, which is far and away the predominant strain in many, many studies of community-associated MRSA in the United States. Here's some data that are unpublished from a study that we're doing in conjunction with Cook County Hospital and our medical center, the University of Chicago. We've pooled our data, and we've estimated in zip codes in the city of Chicago the population-based incidence of MRSA skin infections alone. And we estimate from our data that about 1 in 200 people in the city of Chicago had a community-associated MRSA skin infection in 2007 and in 2008. So when you talk about MRSA now, there are really two almost completely separate things going on in the United States. There's community-associated MRSA and healthcare-associated MRSA. And they differ quite dramatically, both in the history of healthcare contact that's required to be exposed to these pathogens, the sites of infection in the human body, the antibiotic resistance pattern that these strains have, and the high-risk groups who have been identified who become infected with these different strains. I don't have time to talk about the molecular epidemiology, and my talk today is really more about patient risk factors and behavior, but the molecular epidemiology is very relevant to our model as well. This is an unfortunate patient who has a very typical skin infection. So I've seen many patients like this. They come to me in droves in Chicago, fortunately or unfortunately. So I've become quite familiar with things that look like this. And this is a typical skin infection with that's raised red, tender, and has this typical necrotic area in the center. And these are relatively easy to treat, even if they're quite large. They grow very rapidly. But we believe that people's behavior put them at higher risk for getting an infection like this, and people's behavior put them at risk for having a longer period before they are cured of these infections. So just to review a few challenges that we've encountered in developing our agent-based model of community-associated MRSA in Chicago. The first one is that the risk of infection varies geographically dramatically, and this risk varies internationally, nationally, and locally. If you go to the UK or if you go to the Netherlands, you'll see that community-associated MRSA is a very, very different thing from what we have here. And even within the United States, things differ. I studied in medical school and did my residency at Yale. I never saw a community-associated MRSA infection there. And I left there in 2004, moved to Chicago. Community-associated MRSA was all the rage. So we see it every day. One problem with the data on this geographic variability is that there are very few data published. Criteria used to define community-associated MRSA differ in the literature. Of course, many people get relatively minor MRSA infections that don't come to the attention of physicians, and therefore not to the attention of public health officials or researchers. This is a demonstration also of some unpublished data, soon to be published, I hope, of geographic variability within the city of Chicago from the study I mentioned before. These are zip codes in the city of Chicago, and the range of incidence of community-associated MRSA skin infections is indicated by the color of the zip codes. You can see some zip codes had up to 1,500 MRSA infections per 100,000 population in the course of 2008. The second challenge that we've encountered in building our agent-based model is that MRSA is predominantly a commensal organism, as has been mentioned earlier, which means that it lives on us, it eats with us, and it usually doesn't bother us. It rarely causes infection relative to its presence on the human body. And so it's the prevalence data for carriage are sparse, but carriage must be considered when you're making a model of transmission and the epidemiology of this bacterium in a city. There's probably a genetic component to susceptibility to MRSA infections, and that's being studied by several groups, including ours, but we know very little about it. It's expensive to measure colonization in populations. You have to swab people, and the ideal place to swab people on their bodies is not really defined, and it's kind of in flux now. It's not necessarily the nose. And the duration of colonization with community-associated MRSA strains is uncertain, but is critical to understanding the epidemiology of this bacterium. Here's some other unpublished data from a study of community-associated MRSA carriage in household contacts of people in Chicago and Los Angeles who had skin and soft tissue infections. So these data represent positive cultures for Staphylococcus aureus taken from about 1,100 people in 350 households, half of them in LA and half of them in Chicago. What we found when we swabbed people in these three anatomic sites, the nose, the inguinal region, or the groin, and the oropharynx, is that the oropharynx actually was the most common site of carriage for Staph aureus in this population. And if one were to look only at the nares and ignore these other two sites, one would miss colonization 50% of the time with either Staph aureus or MRSA. And these numbers are for any Staph aureus. The third challenge to building this agent-based model is that parameters that describe person-to-person transmission of community-associated MRSA strains are poorly defined. The studies are few and far between. There is some guidance from the literature, but these are mostly in high-risk populations, such as soldiers. And then, of course, in the healthcare setting, there are many studies that give some guidance on this, but they're not necessarily applicable to the household. Probably there is variability in risk for person-to-person transmission across the U.S. population by socio-demographic factors, maybe geographic factors, and other things that we are still studying. So our plan is to derive from the household contact study that I just mentioned, in which we have longitudinal data for carriage in these 1,100 people over a 6-month period, some estimates for risk of transmission of community-associated MRSA from person to person. So what I'm going to talk about today, after all this introductory material, is this study that we just did, which relates to modifiable behaviors and community-associated MRSA transmission risk. So we're doing one study on an administrative database to get a sense of healthcare worker behavior that we think will impact the duration of colonization and the duration of infectivity in community-associated MRSA infected patients. So we're examining how often physicians do incision and drainage procedures, how often they culture patients with skin and soft tissue infections, how often they prescribe antibiotics, and how often they prescribe decolonization regimens. All of these things are described in the recent Infectious Disease Society of America guidelines for the treatment of community-associated MRSA infections as being recommended. And so we're looking longitudinally in a large administrative database to see whether doctors are following those recommendations and how often they are, and if it's changing over time. But the survey that we did, the nationally representative survey that we did that I'm going to talk about today, is about individual behavior. We think that individual behavior in the community certainly plays a role in colonization and infection, and there are few data available. So we turned to this TESS program, which is a social science survey platform that is funded by the National Science Foundation. It has a nationally representative population that's put together by a company called Knowledge Networks. And this web-based survey platform actually allows people who don't have internet access they're provided internet access, so it actually isn't dependent upon people having internet access to be included in this survey platform. So we were lucky enough, we applied for a grant, which we received to launch our survey. One really good thing about this platform is that it's possible to return to the same sample of people over time and to do social science experiments with the same population. So we put out this survey, and these are the domains that I'm going to discuss in our survey. We determined the proportion of the population who had had a previous skin infection, which is, like I said, in the United States. It's the first time we've gotten these type of data in the U.S. In the community-associated MRSA era. We examined attitudes about skin and soft tissue infections, behavior related to skin and soft tissue infections, self-care that people perform if they have a skin and soft tissue infection, use and adherence with antibiotic prescriptions, knowledge about MRSA, and then we tested the impact of a public health message on each of the above. So our survey was administered to 1,980 people. We had wanted to target 1,000, but the uptake of the survey was much greater. It was much more popular among those surveyed than they expected, and we got about twice the population that we had planned. So there are two waves to our survey. The baseline survey, which was just done in September 2011, so we just got these results about 2 weeks ago, involves a vignette where we describe a skin infection, and then we determine how many people with such a skin infection would care for it themselves or seek care from a physician. We asked people about their knowledge of MRSA, and then, like I said, we tested the short-term impact of a public health message. The second wave will be performed 6 months after the first in March, and we're going to assess the long-term impact of a public health message. Our study was randomized and has a 2x2 factorial design. The vignette for the skin infection that we gave to our surveyed population is as follows. We said, imagine that you have a red, painful sore on your skin that is about 1.5 inches across and is starting to ooze thick pus or white liquid. For those who don't know what pus is, you have had the sore for a few days and it seems to be getting worse, not better. So we presented people with this description. We thought about giving them a picture, but we decided the pictures like the one I showed you would gross people out so much they might leave the survey or they might just refuse to believe that such things exist. So we also included on the screen a 1.5-inch round a red circle to indicate what 1.5 inches was for people who weren't familiar with that number. This is a little bigger than 1.5 inches on the screen. So we asked them first, have you ever had a lesion as described? And so for those people who got, I'm sorry, I didn't tell you. So people actually got either the complete description as listed here or they got the description without the bracketed information. So they either got a description of a lesion that is oozing thick white pus or not, okay? So for people who got the draining lesion description, 11.6% of people, and this is adjusted for the characteristics of our sample. We oversampled African Americans and Hispanics, for example. So 11.6% of Americans presumably tell us that U.S. residents have tell us that they have ever had a sore like that draining sore. So over 10%. And about 15% said that among the non-draining scenario group said they'd had a lesion like that. So these numbers, I didn't know these numbers before, and I've been thinking about MRSA for 8 years. So I don't think we have good numbers like this. And so it's something to mull over. So then we said, how likely would you treat such a sore yourself versus going to see a physician? And about half of the people who had a lesion said they would self-treat. In a multivariate model, people were more likely to seek medical care if they got the draining lesion, the more severe scenario, if they were older, if they were more educated. Race, gender, and urban-rural residents did not impact the likelihood that people would treat the lesion themselves. We had 3 different elements of self-care that we believe will affect the likelihood of transmission in a household context that we asked about. So if people did provide themselves self-care, how likely would they be to cover the lesion? And about 2/3 of the people said they would cover it. They'd be less likely to cover it if they were Black or Hispanic, and they were more likely to cover it if they had a draining lesion or if they had a higher level of education. It's recommended that people with active MRSA skin infections don't share personal items that have a lot of skin contact, like towels, razors, and bars of soap, all of which have been implicated in transmission in athletic settings, and in jails less so. And so 60% said they would avoid sharing personal items if they had the lesion as described. Again, people who had the draining lesion scenario were more likely to say that they would avoid sharing personal items, and there were no associations with the sociodemographic variables. Then we said, would you squeeze pus out of this lesion? And 55% said they would squeeze pus out of their lesion. Older people were less likely, and females were much less likely to say they would squeeze pus out of their lesion. There were no other sociodemographic associations. So we believe that each of these could have an impact on the likelihood of transmission from person to person in the healthcare setting. in the household setting. Then we asked people about antibiotic use. This is a very simple thing. You'd think we'd have good data about this. We really don't. How often people fill an antibiotic prescription when it's given to them. How often, when they fill it, they take it until the end of the course. And how often do they fill it and actually finish the medicine? So we gave them this question, and we asked them to choose one of those responses that best fit them. So 5.2% of people said they had never been prescribed an antibiotic in their life. 2.1% said they don't always fill prescriptions when it's given to them by a doctor. 20% said they fill the prescription, but they often stop taking it when they feel better. And about 3/4 of respondents said they fill their prescription and they complete it till the end. And people who filled and completed their prescription tended to be older, have higher education, and were females. They were less likely to fill and complete the prescription if they were Hispanic. So then we asked people, have you ever heard of MRSA? And do you know what it is? And we asked them to give a little statement about what it was. And about 1/4 of people said they'd heard of MRSA and knew what it was. Then the experimental part of our survey, and I know I only have a minute or so to go, was as follows. We gave 50% of respondents, 50% of respondents were randomized to receive a CDC educational message about community-associated MRSA, which was about 5 sentences long. It was taken from the CDC website. There were several bullet points about preventative measures for MRSA in the case that you have a MRSA infection. And then all respondents were asked how serious the lesion described in the vignette was. They had also been asked this question just after seeing the vignette, and they couldn't go back and change their answers. So we found that the CDC message worked. It led to an increased perception of severity of the vignette lesions, and unexpectedly, people who had had the draining lesion scenario were primed, so they were more likely to have a bigger impact from the CDC message. And so now we're going to return to these people in 6 months and ask them about the severity of a similar vignette described lesion. And we'll see if those who got the CDC message 6 months before if there's still an impact of that message later. So in conclusion, what we're going to do with this information on self-care versus seeing the doctor, covering lesions, squeezing out pus and sharing items, filling and finishing antibiotic prescriptions, we're going to apply increased risk to certain sociodemographic groups in our synthetic population for the infective period or risk of recurrence or period of infectivity based on the sociodemographic characteristics that we discovered in our survey. So this is the team of people, mostly from the University of Chicago and Argonne National Labs, who are involved in the MIDAS project and were involved in this research. It was a team effort and an interdisciplinary project to put together our survey. I particularly want to point out Dwayne Wagner in the bottom row there from Ohio State University, who is the PI on this TESS project. Thank you.